So the next session is going to be on etiology and diagnosis of acute pneumonia, and our speaker is Dr. Tanmay Banerjee. So Dr. Tanmay Banerjee is Senior Director in Critical Care Medicine in Manipal Hospitals, Calcutta, India. And he is also heavily qualified, as you can see. He's MRCP UK, MRCP Acute Medicine, EDIC, and he's also qualified in CCST in ICM and AM UK, and he's heavily involved in teaching and also specializes in MRCP teaching apart from critical care teaching, and is a very versatile person in terms of teaching and academics. So with that, I hand it over to you, Dr. Tanmay Banerjee.
So good afternoon, everyone. The topic for today for me is etiology and diagnosis of acute pneumonia. I will start with saying that the infection-related death worldwide, if we consider, pneumonia is on the top, and it is one of the top 10 causes of deaths in all age groups. The clinical challenge is that there are wide array of pathogens, difficulty in etiological diagnosis at times, and there is no single regimen that will cover all the causes. So empirical therapy guided by pathogenesis, clinical presentation, patterns, and microbiological data is important to consider when we treat pneumonias. So as we know, it can be a community-acquired pneumonia, which is acquired outside of the hospital or within 48 hours of hospital admission without features suggesting hospital acquisition. It could be a hospital-acquired pneumonia, which develops more than 48 hours after hospital admission, and that was not present or incubating at admission. Or it could be a ventilator-associated pneumonia occurring 48 hours after endotracheal intubation. Now, I consider, if they're on venti-PAP and on BiPAP also, you might consider, that's not in the definition, but then that is the question, whether that is considered as VAP as well, especially if they're on venti-PAP. So most of my talk I have taken from this ATS IDSA guidelines. So it is a bit old to 2016, but it still holds today. They discussed and decided that HCAP, healthcare associated pneumonia, that term is separate from HAP or VAP, because those includes the patients coming from nursing homes and other healthcare facilities. And this was mainly to cover for MDR pathogens to be considered or not. But then, if we see community-acquired MRSA or community-acquired pseudomonas is not that high, as we'll see in the subsequent slides. So, first to consider the pathogenesis. So we have these host factors, host defense, which starts from the nasal terminates and upper airways, going down nasopharyngeal mucosa, oropharynx, and tracheal bronchial branching, which causes infection of particles of size 2 to 10 micrometer. And also there is surface liquid consisting of lysozyme, lactoferrin, and defensins. Then we have host defense part 2, the alveolar battlefield, where particle size of 0.5 to 2 might enter. First responders will be the alveolar macrophages, which are resident phagocytes inside the alveolus. They eliminate organisms or release cytokines to recruit neutrophils. And then also chemical opsonins, including surfactants, fibonectin, IgG, and complements. So when an organism enters the lung, there is always an inflammatory response. But we have to consider the inflammatory balance scale, which on one hand, we have pro-inflammatory sterilization, like macrophage recruitment of neutrophils via TNF-alpha and IL-1. That is to eradicate the bug. But at the same time, there is anti-inflammatory protection from IL-10 release and receptor shedding. The goal of that is to prevent gross destruction of healthy lung tissue. But at the same time, it is important to consider that there may be key impairments of these host defense mechanisms in conditions such as altered consciousness level, smokers, heavy alcohol intake, which blocks TNF response and impairs neutrophil chemotaxis, some viral infections, HIV, immunosuppressive drugs, COPD, advanced age, and some genetic polymorphism. So when we see a patient with pneumonia, first we need a detailed history to do a clinical evaluation. There should be symptoms consistent with pneumonia. The clinical setting should be as such that we are suspecting an infection, but not a chemical pneumonitis or aspiration, just aspiration pneumonitis or occupational exposure. So history about host defense factors, occupational, animal, and travel history is very important. So the most common and important symptom of pneumonia is cough, and alongside sputum production, shortness of breath, fever, and pleuritic chest pain. But we have to consider that there may be atypical presentations, especially at older age groups, which may include myalgia, fatigue, nausea, abdominal pain, and diarrhea. It could be host factor with advanced age, or it could be the pathogen factor, as we see in atypical pneumonias. So, detailed history taking is important to suspect what type of organisms we are dealing with or what could be the cause. So the clue may be in the contaminated aerosols like air coolers or hospital water or air conditions. It could be a Legionella. If there are bad droppings or bird enriched soil, it could be histoplasma, or rodent droppings could be hantavirus. Then take history of zoonotic exposures and travel history as well. So if there is exposure to infected livestock, milk, or amniotic fluid, it could be Q fever. Birds, parrots could be chlamydia, rabbits and foxes could be tularemia. Also travel geography, like, if you are in Southwest USA, then coccidioidomycosis may suspect, maybe the cause. If you're traveling through a pandemic area or where there is an epidemic of any viral outbreak of respiratory infection, suspect that, like MERS or SARS. And also, like in some geographical areas like Southeast Asia and Australia, it could be melioidosis. So, how we approach to diagnosis? To diagnose community-acquired pneumonia, we have to have newly recognized pulmonary infiltrates on chest imaging and at least one respiratory symptoms, that is new onset or increased cough, new or increased sputum production, dyspnea, and pleuritic chest pain. And one other symptoms or signs or findings, which includes abnormal lung sounds, which could be rhonchi or crepitations, fever more than 100.4 degree Fahrenheit, leukocytosis or unexplained pandemia, and hypoxia, less than 90% saturation on room air. So once you have assessed those criteria in the patient, then have to decide, is it hypoxia or there is a criteria for admission to the hospital, or you can consider outpatient treatment. So that is very important call to make at the onset when you see the patient for the first time in your clinic or in the emergency, because hospitalization has its own implications, costs, as well as risk of hospital-acquired infections. But at the same time, the patient has to be identified whether the patient is fit enough to be treated at home. Because if the patient deteriorates later and comes to the hospital in a more serious stage with severe pneumonia, then you might lose the patient. So we can consider some severity assessment scores, like, when you make the first decision making, there are pneumonia severity index or port score, which considers 20 parameters. Then there are CARF 65, which all know confusion, urea more than 7, respiratory more than 30, low systolic blood pressure, age more than 65, and more than 3 criteria, high mortality needs ICU admission. If you're in the setting at home, you can use CRB 65 without the urea as well. And then there is IDSA or APS ICU category admission criteria, which tells you whether the patient is serious enough to come to ICU. And that has major and minor criteria. So one major criteria or 3 minor criteria, at least 3 or more minor criteria will define ICU admission. So major criteria are septic shock with need for vasopressor or respiratory failure requiring mechanical ventilation. And minor criteria is respiratory rate more than 30 breaths per minute, PF ratio of less than 250, multilobar more than 2 lobe involvement, confusion or disorientation, uremia, leukopenia, thrombocytopenia less than 1 lakh platelet count, hypothermia, or hypotension requiring aggressive fluid therapy. So there have been studies comparing these different kind of scoring systems, like including PSI, SmartCop, and COP65. So they are all not the same. They don't serve the same purpose. But PSI and COP65 tells you about severity and 30-day mortality, the need for hospital or ICU admission. Some newer sort of scoring criteria like SmartCop or even SOFA score may be better in the hospital ICU settings if they're coming to ICU, but still more commonly used criteria is the IDSA ATS severe CAP criteria. So PSI is preferred prognostic tool for determining hospitalization because it best identifies patients suitable for outpatient management. However, PSI and COP65 should not be used alone to determine requirement because they are mostly mortality.
5 minutes left, Dr. Banerjee, 5 minutes left.
For defining severe CAP and guiding ICU admissions, you consider IDSA guidelines. So obviously, 10% of patients as a whole will require ICU admission. And if they're admitted to ICU, there's a mortality of more than 36%, and cost factors are there, of course. Coming to the etiology of community-acquired pneumonia, definitely we have gram-positive, gram-negative atypical bacteria, strep pneumonia and MSSA, and are common, Haemophilus, Monoxella, and then also viruses like influenza, SARS-CoV, as well as other parainfluenza and human metapneumoviruses and rhinoviruses. Atypical bacteria like Legionella, Mycoplasma, and Chlamydia also need to be considered. Less common or unfrequent causes will be gram-positive MRSA or gram-negatives like Enterobacteriaceae or Pseudomonas, but that needs to be considered in appropriate settings if the patient has comorbidities, recent hospital admission, or recent history of antibiotic administration within last 90 days. There's a study I found done in North India, which showed almost 30% or 1/3 of 30.5% of patients were strep pneumonia. Legionella was 17.5%, followed by influenza 15.4%. So that the three most dominant trial in terms of pathogens. Then there is atypical middle tier, which consists of Mycoplasma, Chlamydia, even tuberculosis, and Klebsiella pneumonia. And as I said, there are high-risk patients with comorbidities and recurrent hospital admissions, maybe MRSA, Pseudomonas, or even Acinetobacter. So I'll skip this. So community-acquired MRSA needs to be considered in some cases. You can do a result swab, or you can do a sputum culture or other tests to consider whether you need to do an MRSA cover or not. Normally, we would not advocate that. So, and also Pseudomonas, clinical risk factors like, if someone has cystic fibrosis or some kind of chronic COPD or bronchitis, you should consider them to be high risk for Pseudomonas. So coming to diagnostic techniques, you can use a fiber optic bronchoscope valve, which is obviously best, and if you can take a protected blood culture. So sensitivity is about 36 to 100%, specificity 50 to 77%. If there is a pleural effusion, you can do pleural fluid analysis. Urinary antigen test for Legionella pneumonia or strep pneumonia you can do. And definitely nowadays, we can do a PCR-based test, which can rule out or sort of confirm viral infection suspected and also give the etiology about bacterial infections. If you're taking a bowel fluid, that's best, or you can do from sputum, but you have to think that there may be 89% sensitivity in these cases. And also to consider about doing chest radiographs, blood cultures, sputum strain culture I mentioned, and also biomarkers you can use like ProCal or CRP. So mostly for normal patients being treated at home, you don't need to do all the investigations I'm talking about. But if there is severe cap, you would do definitely blood culture, ProCal, respiratory sample culture, as well as test for viruses and do urinary antigen tests.
2 minutes left, Dr. Banerjee.
Yes, thank you. I'm almost done. I'm not going to talk about treatment, so I'm almost done. So sputum microscopy you can do different kind of radiological imaging, which can guide you about whether it is a lobar pneumonia, is it a bronchopneumonia, is it a bilateral intestinal infiltrates like a viral pneumonia. So those kind of patterns may help you. Even HSCT chest may be more sensitive. And if there is cavity relations, you consider about necrotizing pneumonia or tuberculosis. So these are different kind of patterns, like, that can tell you what kind of pneumonia it is. Obviously, microbiological diagnosis is important as well. And last but not the least, obviously, lung ultrasound and focus nowadays in proper hands, trained operator, it can be a very useful tool which can be quick at the bedside, bypassing the radiology department. So we know, all know the blue. I'm not going to detail into that. So skip the treatment part, but I'd like to mention that you have to think about comorbidities when you are talking about you will give antibiotics or what kind of antibiotics you're giving. So diabetes type 1 with high consensus where there is more than 50%. Well, there was a voting, there was a meta-analysis, and there was sort of a meeting and voting when COPD, end-stage liver disease, end-stage renal disease, cardiovascular comorbidities, alcoholic neoplastic diseases. Think about higher antibiotic maybe, and also even if you're suspecting viral infections, you might need to consider giving antibiotics because you to think that staph infection after influenza infection or viral infections, there may be sort of need for antibiotics. I'm not going to treatment. I'll just finish with my last slide, which is about how to consider and discharge and what to monitor when you're seeing those patients. So every day, assess for clinical stability. At least 5 clinical stability criteria needs to be assessed. That is whether the patient is febrile, whether the patient is tachycardic, tachypneic, respirate more than 24 or not. Is the saturation more than 90% with a PO2 of more than 60? What is the baseline mental status and what is the blood pressure? Is it stable? So those kind of 5 things you have to assess and monitor when you do daily rounds. So key takeaways from my talk, I would say diagnose early. Chest radiographs is the gold standard. Start antibiotics as soon as you diagnose a bacterial pneumonia. But obviously stratify severity. You can use different scoring systems and guidelines to decide whether you need to admit a patient or you can treat as outpatient. First treat empirically, then narrow early as much as early as possible. Minimum 5 days antibiotics is enough in most of the cases. If the bacteria is susceptible, there is clinical improvement by day 3. And also prevent proactively with influenza and pneumococcal vaccination. Encourage smoking cessation in every consultation. Thank you.
Thank you, Dr. Banerjee. I think we don't have any questions in the chat box, but I would like to ask 2 questions from my side. So the first question is regarding the multiplex PCR, sir. So an often seen scenario in most of the hospitals is that when we send the multiplex PCR, it actually gives a report which shows 2 to 3 microorganisms, so like a polymicrobial thing. So how do you go about it? Like which microbe do you choose to treat and which one do you ignore? How do you interpret that polymicrobial report?
Yes, sometimes if you do PCR-based tests like BioFire, you get a colony count. You might get it. So you have to consider whether it is a sputum sample or is it a baggage or protected plastic sample. So if it is a sputum sample, it has to be more than 10 to the power 5. For bag fluid, it can be 10 to the power 2 or 10 to the power 4. Number 1. Number 2, definitely, you might sometimes get viral as well as bacterial, as you mentioned, 3, 4 together. So you will consider that both can coexist. Sometimes it can be colonization, not infection. So clinical and other parameters needs to be considered. The presentation needs to be considered. See, the problem is that cultures take time, and cultures are not as sensitive as PCR-based tests. So, if the patient has severe symptoms and admitted to ICU, I'll go for a PCR-based test to identify early and choose my antibiotics appropriately.
Okay, sir. Thank you. And sir,
Only
the second.
patients who are not getting admitted to hospital or to ICUs.
Okay. And the second question would be for a patient who is in the ICU on a ventilator. And sometimes we send cultures because the secretions from the endotracheal tube has increased and the patient has got a rising WBC count, but there is no patch on the X-ray and there is no hypoxia as such. So the patient does not fulfill the criteria for VAP, but the culture comes positive and we label it as a sort of ventilator-associated tracheobronchitis. Do we treat that with antibiotic or do we just wait? Because now there's a debate that VAT is a continuum of VAP. So where do we stand in that scenario?
Okay. Okay.
As you rightly said, it could be tracheobronchitis rather than actually a VAP or pneumonia. I would like to consider whether the status of the patient. If there is no chest X infiltrates, patient is oxygenation is stable, there is no fever, no leukocytosis or rise in propeller CRP, I would not probably treat and wait. But if any of those I mentioned are present, then I probably would like to treat. Even in the absence of X-ray infiltrates, you might want to get a probably more detailed assessment with a ultrasound, lung ultrasound, or an HRCT to see and be definitive, be more sure that there is no new infiltrates.
Okay. Thank you, sir. So we've got a question in the chat box. Mini ball versus ball for the diagnosis of pneumonia. Which one do you prefer?
Sorry, can you repeat the question, please?
A mini ball versus bronchular lavage for the diagnosis of pneumonia.
Now, bronchoalveolar lavage is probably better, definitely. It depends, at times. If I get a patient who has a very sort of localized infection, like say to lower lobe or middle lobe, like that, those kind of situations, I'll definitely like to go for a bronchoscopy guided lavage. But if I get a sort of widespread pneumonia and sort of bilateral involvement and all that, I'll probably not wait for the bronchoscopy and send a mini bell anyway. But if I want to go for a PCR-based test, I'll prefer to use a bronchoscopy quickly in the ICU and get a sample, valve sample, and then mini valve.
Okay, I think we can take a last question. Dr. Patricio has asked about the New England Journal article that you cited, which showed all the risk factors, strong and weak, to stratify the patients in different groups. So the question is that article does not specify how many risk factors are necessary to group a patient, as in like 2 factors or 3 factors. How many risk factors are necessary to stratify in each group?
Now, in the IDSA criteria, it is very clear that one major or 3 or more minor criteria. For class 65, when it is score of more than 3, then there are sort of other complex scoring systems like which are not easy to do, like the smart cop or even sort of the other criteria, like you need more detailed sort of assessment. So you can use a SOFA score as well, or in the ICUs. So some of the scoring systems are like CAR-65 or CR to decide whether the patient needs a hospital admission or ICU admission. So that is the use of that. Some of them predict mortality at 30 days, which includes the smart cop as well as the CAR-65 as well. So what kind of scoring system you are going to use depends on where you are working and what is your preferences. Not all the scoring systems are the same.
Okay. Thank you so much, sir. Thank you for that comprehensive talk. And I think we can move
One
ahead with
question
the.
from my side, Dr. Banerjee.
Yes, sir.
Yes.
So, Dr. Banerjee, I think one question from my side. What is the current role of PCR? Would you like to do PCR in every patient, or in which patient would you like to do a PCR?
I'd like to do a PCR in a patient who has a severe pneumonia requiring hospital admission, because we need to identify the organism and the antibiotic that is we are going to use early. We're not going to wait for the cultures, but we will not do this in patients who are admitted to the ward, or we are not doing a bronchoscopy in those cases, and definitely not in patients who are at home, being treated at home. But then, if you're suspecting an influenza or something like that, those viral infection, you should test, even if it is an outpatient or not ICU admission, because then there is difference. You are not going to overuse antibiotics and are going to treat the influenza, not just giving empirical antibiotics.
All right. So, Dr. Kushal, please close the session.
Yes. So thank you so much for that comprehensive talk on the
Thank you, Dr.
etiological
Thank you.
diagnosis. Thank you so much, sir.
Thank you.
You want to?
Stop share, yeah.
Dr. Sudipta, please start the next session.
So good morning, everybody, and